over again. Good afternoon and welcome to the part 1 of our 5-part web series on effects of comorbidities on TB nurse case management. If you are joining us as part of your World TB Day program, welcome, and thank you for choosing Heartland National TB Center as part of your program activities. If you are new to our region and this is your first time tuning into one of our webinars, I'm going to go ahead and do a quick introduction. So here are our mission and visions. Our mission is to build capacity with our partners, share expertise in treatment and prevention of TB. Our vision, reflected in excellence, expertise, and innovation, is to develop and implement cutting-edge trainings, deliver expert medical consultation, provide technical assistance, and design innovative educational and consultative products. This is our Heartland region here in the yellow. We have Arizona, Arkansas, Kansas, Louisiana, Missouri, Nebraska, New Mexico, Oklahoma, Texas, and the city of Houston. This is our Heartland team. We have Stephanie Ott, who is our executive director, Alicia Wayne, who is our administrative specialist, Edgar Salinas, who is our website and content coordinator, Jessica Quintero, who is our Director of Education, Delfina Sanchez, who is our Training Specialist, and myself, Josie Gonzalez, Training Specialist. So you can find our training calendar on our website. This is our 2016. It shows each of our courses and webinars that we have coming up this year. If you notice, there is the part 2 that'll be coming up April 12th. For the effects of comorbidities on TB nurse case management. Please make sure that for each of those courses you register individually for each of them. So if you want to just join 2 of the web series, you can do that, or you can join each of them. We'd be happy to have you. So this is the distance training that we offer: webinars, webcast, and online training. We offer technical assistance for PowerPoints, training materials, educational materials, and assistance in planning and coordinating training webinars. Our medical consultation is available Monday through Friday from 8 a.m. to 5 p.m. This is a warm line. And then we have our Heartland consultation, medical consultation group, which is Dr. Barbara Seaworth, Dr. David Griffith, Dr. Lisa Armitage, Catalina Navarro, and Debbie Onofre. We also provide mini fellowships here at Heartland, and if you're interested in participating in a mini fellowship, or if you have a program that you're over and you're interested in your nurses or medical staff coming to a specialized mini fellowship, we are able to do that as well. Catalina is in charge of the medical mini fellowship. We have Jessica Quintero, who's over the contact investigation mini fellowships, and Debbie Onofre, who is in charge of our nursing mini fellowship. So feel free to get in contact with us. We also offer all of our products are free and available for download on our website. All you have to do is go and order what you need off of the product order form, and Alicia will get that to you as soon as possible. I'm sure most of you have already heard about our Heartland's commitment to eliminating stigmatizing language, and here is our commitment to you to use language that is patient-centered, appropriate, and sensitive, and represents the dignity of people with TB and their families. Implement the use of non-stigmatizing language in the creation of our published materials, including products, posters, marketing materials, and speaking engagements. We also promote the use of non-stigmatizing language by working with our speakers to ensure all presentations are free of words such as suspect, TB control, defaulter, non-compliant, and TB case. And our challenge to you is to commit to using language that is patient-centered, appropriate, and sensitive, and represents the dignity of people with TB and their families. Challenge others to join you in your commitment in your local organizations or other programs within your state, and to promote the Stop the Stigma campaign. You can find all of this information on our website. If you go onto our website and click on the Eliminating Stigmatizing Language, it will take you to all of the information that I just discussed. And you are also able to commit to stop the stigma on our website as well. All right, and thank you so much. I'm going to go ahead and get started with our first presenter, who is Catalina Navarro. Catalina has served as a manager for an outpatient medical center for 8 years in Bogota, Colombia. Once in the U.S., she worked as a gastrointestinal and vascular nurse at a local hospital in San Antonio for 3 years. Now at Heartland National TB Center, she serves as a nurse consultant, educator, and assists in the management of U.S. and Mexico TB patients. Catalina has no conflict of interest or relevant financial relationships with any commercial companies pertaining to this educational activity. Welcome, Catalina.
Thank you, Josie. Good afternoon, everyone, and thank you for attending this webinar. As Josie already told you, this is the part 1 of the webinar series that Heartland has prepared for you. In this webinar series, we will address the effects of comorbidities on TB treatment outcomes and nurse case management. And for the remaining webinars, we will invite presenters with different backgrounds and experiences. Okay, it's working. At the end of this series, you will be able to recognize key factors in caring for persons with tuberculosis with one or more comorbidities. And you will identify strategies to improve management of persons with tuberculosis with these comorbidities. But what are the comorbidities that I'm talking about? They are the substance abuse, mental illness, diabetes, and HIV/AIDS. And today I will discuss the reason why we chose these comorbidities and these conditions. I will present the epidemiology of TB comorbidities, and Debbie is going to present the importance of patient assessment with these comorbidities through a case study. But let me start with this information, national information. We all are familiar with this graph that represents the trend of tuberculosis in USA. We have heard for years that since the 1992 peak of TB resurgence in the US, the number of TB cases reported each year has decreased, and it has been a good news. We also know that a total of 9,421 TB cases were reported in the US in 2014. But the number of TB cases reported and the case rate had decreased until 2014. But today is World TB Day. And today is the day when CDC releases the latest information about TB in the previous year. And today, just 1 hour ago, CDC have released this information, and I just want to emphasize what they have shared with us. And unfortunately, I am afraid they are not good news. These are the latest information. They are saying that the progress toward TB elimination has stopped. They are saying that the latest data show that the number of reported TB cases in the US has increased for the first time in 23 years. The message for today from CDC is that a total of 9,563 cases of TB have been reported in 2015, and this is based on preliminary data from the National TB Surveillance System. This represents an increase in 150 cases from the 9,406 cases reported in 2014. This is the first time since 1992 that the annual number of reported TB cases in the US has increased from one year to the next one. So this is not good news. CDC also mentioned some talking points. They said that TB cannot be eliminated in the US without increased efforts to test and to treat latent TB infection among high-risk groups. And I want to emphasize these high-risk groups. Who are them? The current US efforts to rapidly diagnose and treat TB disease are essential, but they are not going to be enough to eliminate this serious problem in US. And I have seen the same similar message since 2011, when Dr. Mario Raviglione, the director of the Global TB Program at the World Health Organization, he said that TB control was not going to be conditional in significant medical advances. It was not going to be conditional in new medications, new lab technology, or rapid testing. It would depend when we are going to be able to address the social determinants of tuberculosis. We have to work in those risk factors, in those social problems that our patients with tuberculosis have. What are these problems? What are these risk factors? They are HIV infection, smoking, substance abuse, alcohol abuse, diabetes, and mental illness. And this is one of the reasons that we decided to do this webinar series, because if we don't pay attention to these special situations, we are not going to be able to eradicate tuberculosis from our country. The World Health Organization also published this document in May 2014. This is the framework towards TB elimination for low-incident countries. And low-incident country is defined as a country with less than 100 TB cases per 1 million population a year. And if we do the map, US has 30 TB cases per 1 million population. So we meet this criteria, and we are classified as a low incident country. So this document is for us. This document is intended to provide priorities, challenges, and strategies for TB care and prevention to help us in the race of TB elimination. So I encourage you to download this document and to review it. In this document, they mention 8 priorities. This is the list of the 8 priorities that we have to work on, but I just want to emphasize on 2. In order to work on TB elimination, let me get that here. Thing is not working. Okay, I'm gonna emphasize in the number 2 and the number 4. In order to work on TB elimination, we must address the most vulnerable population and the hard-to-reach groups. And we must begin screening LTBI and TB disease in selected high-risk groups. Again, these high-risk groups are the ones that we have to find, that we have to screen. Most of the time, this vulnerable population don't seek healthcare. They don't go to our clinics. They are the vulnerable population. And I'm going to talk about vulnerable groups. In the same document, they talk about the challenges for TB care and prevention in our country, in low incident countries. And they said that TB is concentrated in vulnerable groups. Who are them? They are the people living in poverty, homelessness, migrants, people living with HIV/AIDS, people with alcohol abuse and substance abuse, people incarcerated, all the marginalized groups. So it's the same message. We have to work in the social determinants of tuberculosis. But why they are vulnerable? Because they need special care. Why we have to care about them? Because they need our support. They need our protection. They need our attention because they are always neglected. And they are the group that they always have poor outcomes. Why they have poor outcomes? Because maybe they have mental illness, they have substance abuse, they are stigmatized, and they don't go to our clinics. So we need to work in these social determinants of tuberculosis in order to have better outcomes in the treatment and better numbers, the numbers of rate of TB. Just to mention briefly, the strategy to face these challenges is still the same. CDC gave us the CDC guidelines in 2003, and they mentioned that we need to, their strategy is going to be patient-centered care. It means that we have to care for our patients. We have to have a caring relationship between the nurse case manager and the patient. Nurses should know and respect patients' values, patient beliefs, hopes, adversity, in addition to patients' clinical symptoms and concern. In this context, the nurse case manager can work to provide personalized care that is in agreement with the needs of the patient. And I want to highlight the definition of nursing assessment that is given by the American Nurses Association, that the assessment is not only physiological data, it's not just symptoms, it's not just family problems. It's also psychological, socio-cultural, spiritual, economic, and lifestyle. Okay, I'm going to start with the epidemiology of substance abuse. In 2014, 27 million people aged 12 or older use illicit drugs in the past 30 days. 27 million from the whole population in US. It corresponds to about 1 in 10 Americans. This percentage in 2014 was higher than those in every year from 2002 to 2013. So the problem with substance abuse is increasing in USA. The illicit drug use estimated is driven by the use of marijuana, with 22 million people using marijuana, following by 4 million people using prescribed pain relievers. This data was taken from the annual survey of drug use and health conducted by the Substance Abuse and Mental Health Services Administration. If you go to the web, you are going to find different data from different organizations. This data, I really like it because in detail, they give us data about drug, alcohol, and tobacco use by all ages, starting 12 years of age. This is a good resource of information on substance abuse and dependence among Americans, and I recommend this, this page. More than a half of the new illicit drug users begin with marijuana. 70% of the new substance abusers started with marijuana. The next most common are prescription pain relievers, followed by inhalants. When we talk about substance abuse, we always think in illicit drugs. But there is another epidemic that is overwhelming USA. It's the epidemic of prescription drugs. Nearly 2 million Americans abused or were dependent on prescription opioids in 2014. Overdoses involving opioids killed more than 28,000 people in 2014. Over half of those deaths were from prescription drugs. The chart to your right shows the total number of US overdose deaths involving prescription drugs from 2001 to 2014. The chart is overlaid by a line graph, one in yellow and one in orange, that show deaths by females and males. From 2001 to 2014, there was a 2.8-fold increase in the total number of deaths for overdose from prescription drugs. United States is in the midst of a drug overdose epidemic. And this is really alarming. This chart shows the total number of US overdose deaths involving heroin from 2001 to 2014. Also, the chart shows the graph, the yellow line, females, and the orange line, males. From 2001 to 2014, there was a six-fold increase in the total numbers of deaths. Six-fold increase. Men are nearly 4 times more likely to die from heroin overdose than women are. This is the 5th year in a row that heroin deaths have increased. And more people die from heroin overdose in 2014 than in any other year on record. The magnitude of the overdose deaths from heroin is really alarming in USA. The problem is so severe that some states have declared a state of emergency because of the overdose of heroin. And other states are struggling with the lack of rehab centers to treat all the people that are abusing heroin. 2 weeks ago, I watched the ABC 2020 TV show. It was called Heroin in America, The Breaking Point, and they addressed this problem of heroin in New Hampshire. They interview people from public health. They show really shocking stories, and I will invite you to watch that program because really it's showing the reality of the heroin overdose in America. And we as nurses in public health should promote and implement prevention and early intervention strategies to reduce this social problem. Okay, the next topic is mental illness. According with the World Health Organization, the burden of mental disorders continues to grow with significant impacts and major social, human rights, and economic consequences in all countries of the world. Globally, over 20% of adults aged 60 and over suffer from a mental illness or any neurological disorder. Mental health problems are most of the time under-identified, are sometimes misdiagnosed by healthcare professionals and older people themselves. And the stigma surrounding mental illness makes people reluctant to seek help. Does it sound familiar to you? They are some of the vulnerable population that is mentioned in the document of TB elimination. This is the high-risk population. They are the vulnerable population, the hard-to-reach population that CDC is recommending to find and to screen for latent TB infection or for TB disease. But how we are going to find them? That is the question. Mental illness in USA. In 2014, let me get the R. In 2014, almost 44 million adults, is 1 in 5 adults age 18 or older had any mental illness. 44 million people in USA. And from these 44 million, almost 10 million people has serious mental illness. What is the definition of serious mental illness? There are diseases like schizophrenia, bipolar disorders, psychotic disorders, or major depression. So 10 million people has serious mental illness in USA. The overlap of substance abuse and mental illness is large, and most of the time we see people with mental illness that have been identified as substance abusers. As many as 6 in 10 people with, that have substance abuse also suffer from mental illness. From 20 million people with substance abuse and 43 million people with mental illness, almost 8 million overlap these two conditions. 8 million people in US have mental illness and substance abuse. By the high prevalence of these comorbidities doesn't mean that one condition can cause the other condition, even if one appears first. There are at least 3 scenarios that we should consider. Drug abuse can cause a mental illness. Mental illness can lead to a substance abuse, but drug abuse and mental disorders are both caused by other common risk factors. And we all see in our clinics people that have these two conditions. We are going to talk more about these problems in our webinar, in the next 2 webinars. Overlapping serious mental illness, those people with schizophrenia, bipolar, depression, and substance abuse is also a huge problem in US. From 20 million people with substance abuse and 9 million people with serious mental illness, more than 2 million people with serious mental illness overlap with substance abuse. The relationship between mental illness and TB is complex. Now talking about tuberculosis. Mental disorders are associated with high risk of TB acquisition and transmission. Poor adherence to anti-TB treatment is also associated with mental disorders, and diagnosis of TB increases the risk of mental illness. So we have these overlap conditions. The risk of mental illness in patients with tuberculosis, these are studies from the General Hospital Psychiatric Journal. They were published in 2013. Up to 70% of patients with tuberculosis have any kind of mental illness. Also, a study in Peru found rates of depression and anxiety at 52% and almost 9% among patients with MDR-TB. Also, prevalence of depression correlates with the disease severity and duration. And another huge problem is if you have tuberculosis and is co-infected with HIV, they may increase the risk of depression to 70%. So addressing psychosocial factors and mental health is necessary to ensure positive treatment outcomes of TB. Okay, diabetes, epidemiology of diabetes. Maybe you all know about the epidemic of diabetes in USA. 29 million people have diabetes. That's about 1 out of 11 people. 1 out of 4 don't know that they have diabetes. And regarding pre-diabetes, 86 million people, it means that 1 out of 3 adults have pre-diabetes, but 9 out of 10 don't know that they are pre-diabetic. What is the linkage between tuberculosis and diabetes? When the patient is diagnosed with diabetes, the immune response is compromised. The immune response is weakened. If this person is exposed to tuberculosis, they, with the immune system really weak, increase the risks for latent TB. People with a weak immune system as a result of chronic diseases such as diabetes are at higher risk of progressing from latent TB infection to active TB disease. People with diabetes have 2 to 3 times higher risk of TB compared to people without diabetes. About 10% of TB cases globally are linked to diabetes. Along the US-Mexico border, the report is that diabetes is the most frequent risk factor for tuberculosis. Globally, urbanization has fueled an increasing incidence of diabetes in Africa, India, Asia, South and Central America, and the US, and many are areas with high rates of tuberculosis. By 2030, it is estimated that 80% of diabetes will be in areas of the world with the highest rates of tuberculosis. So diabetes is really a problem. We are going to try to eliminate TB from our country. Growing diabetic epidemic will have a significant impact in TB care. Epidemiology of HIV/AIDS. In 2014, an estimated of 44,000 adults and adolescents were diagnosed with HIV infection. 80% of these 44,000 were among males and 19% among females. So HIV is more common in males. Gay, bisexual, and other men who have sex with men, that is called MSM, particularly young Black African American, are most seriously affected by HIV. More than 1.2 million people in the United States are living with HIV infection, more than 1.2 million. And almost 1 in 8 are unaware of their infection. They don't know that they have HIV. 1 in 4 new infections are among young ages, like 13 years to 24 years of age. And most of them don't know that they are infected and they are passing the virus to others. So HIV is another alarming problem in US. As I told you, by race, Black African Americans face the most severe burden of HIV, followed by white and Hispanic. Black American with the 44%, white with 27%, and Hispanic with 24%. This is almost the same information about new infection by most affected risk group. The gay, bisexual, and other men who have sex with men of all races and ethnicities remain the population most profoundly affected by HIV. This is the white men having sex with men, Black, and Hispanic. AIDS statistics. In 2013, an estimated of 26,000 people were diagnosed with AIDS. AIDS is the stage of the HIV infection that occurs when the immune system is really damaged and the person becomes vulnerable to opportunistic infections. AIDS is the final stage of HIV infection, and not everyone who has HIV advances to this stage because they have to start with the antiretroviral therapy. But regarding AIDS, an estimate of 1 million people in the United States had been diagnosed with AIDS. And an estimate of 13,000 people with AIDS diagnosed died in 2012. So people with AIDS need medical treatment to prevent death. This slide represents the trends in the estimated numbers of adults. It's almost the same information, but I just wanted to emphasize that the male having sex with male is increasing really rapid, followed by this is the heterosexual contact are also increasing. But the challenge of TB HIV. This graph is an estimate of TB and HIV co-infection in USA, and in 2014, 9% among persons aged 25 to 24 from all the total TB cases were co-infected with HIV. And the challenge of HIV and TB. Individuals co-infected with HIV and TB are 30 times more likely to progress to active TB disease. Infection with TB enhances the replication of the HIV, and it can accelerate the progression of HIV infection to AIDS. And TB is the leading killer of people who are HIV infected. And this is the last slide. Now Debbie will be presented a case study. And if you have any questions, I believe at the end of Debbie's presentation, we have some time to answer. And thank you so much for your attention, and I hope you enjoy this webinar. Thank you.
Thank you so much, Catalina. All right, so we are going to go on to our next presenter, who is Debbie Onofre. Debbie served as a charge nurse for the Texas Center for Infectious Disease, working primarily with population of patients infected with TB. Her experience included direct nursing care to patients who were hospitalized at TCID, both on a voluntary and protective custody basis. She also served as a senior public health nurse for the City of San Antonio Metropolitan Health District, managing TB cases, suspects, and LTBI patients. Currently, she serves as a TB nurse consultant and educator for Heartland National TB Center. Debbie has no conflict of interest or relevant financial relationships with any commercial companies pertaining to this educational activity. If everybody could please welcome Debbie. Are you there, Debbie?
I am. Can you hear me? Hello?
I can hear you.
Okay. So thank you everyone for joining us this afternoon. And thank you, Catalina, for the information that you presented today. That was great. So Catalina discussed several comorbidities and challenges associated in providing adequate anti-TB therapy for patients who have TB and comorbidities. I'm going to present a case study about a 26-year-old female who had some of the comorbidities that Catalina discussed in her presentation. And I'm going to touch briefly on why it's important to these that we recognize these comorbidities and treat them concurrently with anti-TB therapy. I always forget how to advance these. Okay, here we go. So we have a 26-year-old Caucasian female who presented to the ER in the last trimester of her pregnancy. She presents to the ER in labor, but also has a terrible cough with hemoptysis and fever. She reported having night sweats, weakness, and a 40-pound weight loss since the beginning of her pregnancy. She delivered the baby during this hospitalization at 32 weeks gestation. Her weight when she delivered was 85 pounds. She actually reported her average weight is usually around 126 pounds. A chest x-ray was done after she delivered, and it noted right upper lobe cavitary infiltrates, indicating that she probably had advanced disease, and she likely had TB for a while. A TST was done, and that was non-reactive. Sputum specimens were collected for AFB smear and culture, and these were positive for Mycobacterium tuberculosis without drug resistance to any other TB medications. After a couple of days, she was discharged from the hospital and was told to report to the local health department for initiation of anti-TB therapy. So she goes to the health department to start TB treatment. A thorough nurse assessment was done and revealed the following. The patient reported a history of asthma with at least 2 asthma-related ER visits in the last couple of years. She reports a history of bipolar disorder that she had not received treatment for approximately 2 years. And then as part of the nurse assessment, we did a social history, and the patient reported a history of substance abuse for several years. She reported using ecstasy, methamphetamines, crack cocaine, and alcohol, 4 to 5 40-ounce beers per day. And she also told us that she uses crack cocaine, or she had been using crack cocaine and alcohol every day for 18 months prior to her recent hospitalization. She has a history of homelessness. She had been homeless for 3 years and had been staying at a homeless shelter and with friends and on the streets on and off. And then she also reported multiple incarcerations since she became homeless, which were mostly related to public intoxication. Okay, so here's a question for you. The nurse assessment identified some comorbidities. Why is it important to recognize these? Is it A, so that we can identify drug interactions? B, because we may need to monitor her closely for toxicities to anti-TB meds? Or C, because we need to identify barriers to treatment? Or D, all of the above?
All right, if everybody would like to go ahead and click on which answer you think is the correct answer.
And it looks like the majority of you voted correctly.
Yes, I'm going to go ahead and end the poll.
Okay, so correct. The answer was D, all of the above. So it's important to recognize these so that we can identify drug-drug interactions if she's taking medications for other health issues. Let's see. Because we may need to monitor her closely for toxicities to anti-TB medications. We do monitor our patients with TB closely, but because she has a history of substance abuse, she gets to be monitored a little bit even more closely. And we need to identify barriers to treatment early into anti-TB therapy. So yes, D was all of the above. And barriers to treatment are anything that could potentially interfere with treatment. Some examples of common barriers to treatment include lack of motivation. A patient may have limited desire to be treated or may not be willing to be treated because they don't believe that their diagnosis is correct. Location to treatment. It may be difficult for the patient to go to the clinic because it's too far for them, or they may lack transportation. They may not be able to drive to get to the clinic for evaluation or treatment, or they can't afford to pay for a taxi or bus fare. Cultural barriers may also interfere with the patient's willingness to be treated. And lack of support system might also be a barrier. They may have dysfunctional family dynamics or a limited support system. Drug or alcohol addiction, that's definitely going to interfere with treatment. And untreated mental illness could be a barrier if it isn't being treated or managed. If it isn't being treated or managed. Homelessness, persons who are homeless are often very mobile and moving from place to place, and this makes it difficult to receive treatment. So those are just a few barriers, to treatment, but anything that might interfere with treatment could be a potential barrier to treatment. And that's why it's so important that we identify comorbidities and manage and treat them while we're treating our TB. So we recognize that managing this patient's TB might be a bit of a challenge because of her history of incarceration, homelessness, substance abuse, and untreated bipolar disorder. But anti-TB meds need to be initiated. So what are we going to do? Do we A, report this to the state and give the patient an appointment to return next month? During this time, community resources will be identified and shared with the patient when she returns. Do we B, give her 2 weeks of TB medications for self-observed therapy? She's homeless and locating her may be difficult for DOT. Do we C, do nothing until we identify appropriate community resources to share with her? Do we D, initiate DOT, provide education about side effects and toxicities, and monitor her closely, and then provide her with community resources to assist her?
If everybody'd like to go ahead and poll in. Looks like the majority is D. I'm going to go ahead and end the poll.
Okay, so the correct answer is D. You're right. Initiate anti-TB therapy, provide education about the side effects and toxicities about these medications, monitor her very closely, and then provide community resources. Okay, but let's review the other answers. So A was report this to the state and give the patient an appointment to return next month. During this time, community resources will be identified and shared with the patient, or when she returns. Okay, so this is wrong because we will be reporting it to the state, yes, and she will be returning next month, but we really do want to identify any and all barriers to treatment immediately so that we can provide community resources right away. The nurses should take a proactive approach and always be on the lookout for community resources. That way, they can have this list. This way, when they need to provide assistance, this can be done ASAP, and this shouldn't wait an entire month. B was give 2 weeks of TB medications for self-observed therapy. She's homeless and locating her may be difficult for DOT. This happens more often than I wish it would. It happens quite a bit, but this is not correct. Self-observed therapy in this situation is a big no-no. Even though she's homeless and she might be difficult to locate, we must provide DOT to this patient, especially given that she has a substance abuse background. We need to monitor her carefully for toxicities, and this can only be done by DOT. Okay, the next answer was C, do nothing until you identify appropriate community resources. That way we can share it with the patient, and this is just wrong. We always try to do something. And then again, D was the correct answer. Initiate anti-TB therapy, of course. Provide education about side effects and toxicities. And then we might also want to give them our phone number that way they can report these toxicities if they do occur. And then monitor her very closely. If she's got substance abuse issues, she did report alcohol abuse, so we may have to monitor her, or we will be monitoring her LFTs closely. And then later on in this series, we're going to go over into a substance abuse case study, and we'll be talking about everything that you need to look for when you're monitoring these patients. So I'm not going to go into it a whole lot. But we also need to provide community resources to assist her. Okay, and always remember, we want to ask lots of questions. This is going to be an ongoing process before the patient feels comfortable sharing anything with the nurse. But we need to make sure to try to get as much information as we can so that we can provide necessary resources for these patients. And by doing this, it's going to increase the likelihood that our patients will adhere to treatment and be, complete treatment adequately. So we need to evaluate further and ask what, when, and where. For example, with the bipolar disorder, we need to confirm the diagnosis. As a nurse, I'm going to ask the following. When were you diagnosed? Where were you diagnosed? I want to do my best to find out the provider's name and location who had treated her, maybe get his phone number, and then call him and see if I can get my hands on any of these documents so that I can figure out what she was treated with in the past and if that worked for her, and then get her linked up with a psychiatrist in the community so that she can get started on these treatment on her bipolar meds. So for this patient, she told us she was diagnosed and treated for bipolar disorder at a rehab facility. So we contacted the facility and made, this took several attempts. It wasn't something, where I called them and they answered and they gave me the information I wanted. No, I had to bug them a lot of times, and they finally shared the information we needed. So we got her linked in with a psychiatrist through a community clinic, and she was restarted on treatment for her bipolar disorder. And she did have a few minor ups and downs with the antipsychotics when she was first started, which is pretty much, I'm thinking that that's why she stopped her meds a couple of years ago. But the side effects were managed, and she was eventually able to tolerate the meds for her bipolar disorder. And then she also got linked in with the local Alcoholics Anonymous chapter and received substance abuse counseling. And she remained without permanent housing until she got a job. She worked as a temporary employee near the clinic, and they eventually hired her as a full-time employee. And then at that time, when she got money, she was able to save money. She was able to get her own apartment. Because we identified challenges with treatment early into anti-TB therapy, being the comorbidities and other social challenges that we had, we were able to recognize potential barriers to treatment and address those right away by providing appropriate resources and monitoring her carefully. Because of these efforts, the patient completed adequate anti-TB treatment successfully. She had good adherence to TB and antipsychotic medications. She gained over 40 pounds during her treatment. She maintained sobriety throughout treatment, and then she maintained her job in her home. So she's done pretty well. Her child is healthy and was adopted by family members. She reestablished her relationship with her child and her parents. She has since gotten married and continues to maintain sobriety. And she wanted me to share the following with you who are watching today. She said, thankfully to the healthcare providers who took care of me when I had my baby, they were knowledgeable about TB. They recognized that I had TB. They saved my life. TB saved my life. And this is truly a success story. We're proud of her, and we're proud of everybody, all the healthcare providers who are involved in her care. But I'd like to take this opportunity to point out that the patient's TB could have been diagnosed earlier. Her healthcare providers who cared for her during her many ER visits should have recognized TB symptoms. Staff at the homeless shelters, they should have been able to recognize these symptoms. She had multiple incarcerations where she could have been screened for TB, but she was never screened at the hospital, at the homeless shelter, or at the jail. So we need to become more knowledgeable about TB and share our insight about our TB with our colleagues. We need to be able to recognize signs and symptoms of TB in an effort to prevent delay in diagnosis and reduce incidence of TB. And remember, the nurse assessment is such an important component in TB nurse case management. It must be thorough and include an interview with and evaluation of the patient to identify signs and symptoms and all barriers to treatment, including comorbidities, which may interfere with treatment or may make treatment more complicated or challenging. So in this series over the next few months, we're going to be focusing on key factors caring for patients with TB and other comorbidities, and then identifying strategies to improve management of TB with these patients. And that's all I have. Thank you very much.
All right, Debbie, thank you so much. We appreciate your time. We do have a question at the bottom from Terry, who asked, did you use any incentives or enablers for this patient?
So yes and no. So we had some incentives. We used bus cards. Basically with her, it was more of, showing her some sort of, we showed her that we cared, and that really went far with this patient. She really needed to see that someone still cared about her. So, we offered an ear. We told her about all these resources. We told her how, all along while she was getting treated, we told her we were her cheerleaders, and we told her how well she was doing and gave her lots of pats on the back. But as far as incentives and enablers, there wasn't a whole lot that we could provide for her except getting her linked with the community, getting her a job, getting her, she got her own housing through that job. And by seeing those successes, that just drove her more to want to get treated successfully, seeing that she could still, do something good for her life.
Great, thank you. We have a few more minutes for other questions. I see some people writing right now. Was there a period where this patient was quarantined from the public, and if so, how was this accomplished?
So there was an infectious period, and she was quarantined from the public. She was actually at TCID for a little bit in the hospital. So, and then she got discharged to the community.
Okay, and we still have Catalina on the line. So if anybody has any questions regarding statistics or anything from the first half portion of our webinar, if you'd like to go ahead and key in your questions.
So back to Julie's question.
Yes, go ahead.
I was also a nurse case manager with the city of San Antonio. When, and I had, this particular case was very similar to many of the cases that I managed, where the option was not to come to a TB hospital, and we have all of these resources available. And so what we did at the city chest clinic, when I was a case manager, is we often provided housing for them in a hotel, in a motel. And the city funded that for that patient during the time that she was infectious. And
Okay,
DOT was.
Oh, yes,
DOT
you got it.
was very difficult. Lorraine is asking, was DOT difficult? Yes, it was very difficult. Initially, she wasn't very trusting of us. She did believe that she was sick, and she knew she had TB, but we had to address her bipolar disorder. We had to address, the fact that she was homeless initially. We had to address everything that I mentioned before we could get DOT to be successful. So initially, the first few weeks actually, she missed several doses because, it was either a matter of, just non-compliance with her. And she did have a history of incarceration. Yes, it was due to public intoxication, but that also is a red flag for, I don't follow rules very well. And this patient really didn't follow rules very well. And so Melanie is asking, what were the AFB smear results for this patient? She was smear positive greater than 10, culture positive, and she was pan-susceptible.
Okay, and we'll go ahead and take the last question, which was, how did you get funds from the city? And was this an effort with the state TB program?
So funding from the city, that was something that was available to us as a resource. I can't tell you because it was, I worked for the city 9 years ago, so I don't remember exactly where the funding came from, but we had that set up for some patients in these situations. So that was, while I was there with the city, I must have found hotels for patients at least 5 times. So that was something that happened a little bit more often than we wanted to.
All right, well, thank you so much, Debbie, for your time. And I'm going to go ahead and end this webinar.